Hi, I'm Dr. Leah Hillier, and this is a presentation on pediatric sports medicine. So briefly, our agenda is going to include reviewing youth sport participation. We're going to talk about pediatric physical activity guidelines in Canada. We're going to review early sport specialization and some associated issues. We're going to discuss the physiologic differences between children and adults that are relevant in sport. In the second half of our presentation, we'll discuss pediatric-specific musculoskeletal issues, and then we'll finish up discussing some sport-specific issues in kids. So just a couple of quick facts about youth sport participation. We are seeing increasingly numbers of younger and younger kids getting involved in organized sports. Interestingly as well, we're seeing a bit of a migration to the extreme. So although we're seeing kids getting more and more involved in organized sports, we're also seeing increasing rates of pediatric obesity. So let's talk about the physical activity guidelines and what we should be recommending to our young patients in terms of activity levels. So on the next slide, you're going to see me with a little bit of So I'll show you the reference on the next slide where this information came from, but this is the Canadian Society of Exercise Physiologists guideline for kids aged 5 to 17. It's recommending 60 minutes a day of moderate to vigorous activity, and at least 3 of those days should include activities that strengthen muscle and bone. Obviously, more physical activity is better here, and we're going to see more health benefits with more active kids. So there's just a screenshot here of the csep.ca page here where they have the guidelines. You'll see a drop-down menu here that shows guidelines based on age. There are also a number of guidelines provided here for special populations. These are certainly worth taking a look at. 1, because they're important for practice, but 2, because this is probably examinable information. I'll make a quick reference here to the Canadian Pediatric Society guideline as well. This guideline has a little bit more qualitative information around physical activity for kids. There are equivalent US guidelines that have similar information but are also worth taking a look at if you have some time. So let's talk about early sport specialization and overtraining. I'm going to define sport specialization as intensive year-round training in a single sport to the exclusion of other sports. So why does this happen? Well, there are a number of different motivating factors for sport specialization at an early age. First of all, people often think that this is going to give their child or themselves an edge in competition. There's a feeling that it will take them on a more direct path to things like college scholarships, professional contracts, and membership in national or Olympic level teams. And also, they're looking at younger and younger elite level travel team selection. Interestingly, there are multiple studies which suggest that the coach is the primary driving influence in single sport specialization. So that might be a target of some education for us around some of the facts that we're going to get to on the next slide. So there are risks with early sport specialization. A couple of the concerns that we think of as physicians are overuse injuries and psychological burnout in these young people. There is considerable controversy as to when, how, and why a young person should become a single sport athlete. Some data suggests that early sport specialization doesn't actually lead to a competitive advantage over athletes who participate in multiple sports. And those who participate in a variety of sports and specialize only after reaching puberty tend to actually be more consistent performers, have fewer injuries, and adhere to sports play longer than those who specialize early. There's a study done in 2012 where they looked at over 1,000 17 and 18-year-olds, and that study demonstrated that choosing a sport to focus on was an independent risk factor for injury even after adjustment for age and hours a week in total sports activity. We've also seen some benefits in later specialization. So some studies have suggested that late specialization in a particular sport may actually result in better athletic achievement than early specialization. The caveat to this is that some studies have suggested that early specialization is actually helpful in highly technical sports. So things like rhythmic gymnastics or dance might actually be better served by athletes who specialize earlier. So a quick summary slide here that just has some key issues, facts, and numbers which are helpful in dealing with pediatric exercise and sport specialization. First of all, single sport specialization before puberty seems to put athletes at some risk of injury. Also, elite athletes are more likely to have delayed single sort specialization until after puberty. So if you look at people who have perhaps better better athletic achievement, often they've been people who have delayed their sport specialization. A good ratio to keep in mind is 2-to-1. And that's a ratio of organized sport to free play time for young people. So you don't want them to be doing 3 hours of organized sport for every hour that they get a free play time. We want to give kids time to actually be kids. Another rule that's helpful here is that kids should not be participating in more organized sporting hours than their age and years. Kids should sleep more than 6 hours on nights before activity, and that's a good thing to keep in mind because we do see increasing injury rates in kids when they have been active and not sleeping the night before. So let's look at our pediatric musculoskeletal history. Some of these things obviously are very similar to what you're doing in your adult history, but a few of them are a little bit different. So first of all, of course, your ID. So knowing the age is important, the gender is important, and handedness or footedness based on the body part involved is helpful. You're going to do a good history, the location of the pain. I find with kids it's good to say, can you point to where it bothers you or point to where it hurts? And that way they can kind of get you focused on what you're dealing with. You want to know when the symptoms started. Obviously, you might look for an acute injury or a trauma versus an insidious onset, which might point us more towards an overuse injury. You want to know the mechanism if there was a specific irritating or inciting event. And then knowing if there was any change in training load is helpful too. Did they get new shoes? Are they running on a new surface? Did they start a new sport and add something in that they weren't doing before? Aggravating and relieving factors is going to play into that. And then doing a good summary of their symptoms. So do they have pain, swelling, paresthesias, clicking, mechanical symptoms, stiffness? And the big one for kids that I find helpful is function. So are they still playing their sport? Are they still getting involved at recess? Are they not doing anything? And knowing their function is going to be helpful. And just like your adults, you're looking at allergies, medications, past medical history, surgical history, and an injury history. You're going to, with their activities, walk through their level of training. So you want to know their level of competition. How many hours a week are they doing this? Are they doing some other sports at the same time? And I always ask kids what they want to be when they grow up or what their plans are with their sport. It's nice to ask this with the parents in the room because you can gauge a bit of the response from the young person and also from their parents. I get into a development history for a number of reasons. First of all, you want to know if they're in the midst of a growth spurt. How much have they grown? Over what time period have they grown? Are they accelerating into the growth? Are they decelerating out of the growth? That's going to give you a little bit of an idea of their predisposition for certain injuries. With young women, you're always asking about menarche. There are a couple of good reasons to ask about this. The first is that it gives you a bit of an idea of where they are with their bone growth and their growth plate fusion. The second is that it helps you to evaluate for things like relative energy deficiency. And there's a great talk on that, which is also part of this series that you can take a look at. When I ask about social history in kids, I ask them what grade they're in. I find out their parents' names. I ask a little bit about the home situation and then any other sorts of hobbies or interests outside of their activities, their normal sports. And of course, a family history, asking about any sort of rheumatological or connective tissue and MSK issues in the family. Anytime I ever see a pediatrics presentation, I feel like somebody puts this slide up and says children are not tiny adults, but I do think it takes, we should take a moment and look at it. The reason for that is there are a number of considerations in kids in terms of musculoskeletal pathology that will not be on your differential for adults. So you might have an adult come in with a similar presentation, story, and clinical exam to a child, and you're going to see very different differential diagnoses and pathology. So it's good to step back and think about kids as a little bit different entities from adults. So let's talk about some of the physiologic differences and things that you need to think about with kids that you maybe won't worry about quite the same way with adults or in a different way. So nutrition. Kids who are engaged in sports where slenderness is considered important, so things like gymnastics and ballet, can actually be at risk of compromising growth. So there are risks for pathologic eating behaviors in these types of sports, and you want to be looking for them if leanness is rewarded. Particularly, I think about inadequate calcium intake. It's relatively common in athletes, presumably because of concerns about fat content in dairy food. But it's pretty critical for normal bone growth, so it's something to really watch for. Also, it might help us in terms of healing things like stress fractures. Heat regulation is different in kids versus adults, so they have a different thermoregulatory response. They sweat less, they create more heat per body mass, and they acclimatize slower to warmer environments. So they are at a higher risk for heat-related injuries. There was just a little study here that I found that I thought was interesting where they tried to look for any sort of negative cardiac effects on kids based on cardiac training. They couldn't find anything, so there's no reason to stop kids from intense athletic training. Sexual maturation has lots and lots of points on it, so we'll go through this quickly. We've talked about it very briefly already. Age of menarche normally for young women is 12.3 to 12.8 years. That of athletes is typically 1 or 2 years later, so athletes usually experience menarche at a later age. There's concern that intensive sports can delay sexual maturation. We think that's because of training stress, undernutrition, and low levels of body fat. This is different than secondary amenorrhea, where you actually have cessation of menstrual cycles after menarche. And this we see often as a result of intensive athletic training. This might be a sign of relative energy deficiency syndrome. Prolonged amenorrhea can be a problem because we see diminished bone mass from the associated decrease in estrogen secretion. And this is critical because those teenage years up until the early 20s are the time when women are building their bone mass the most. So it's really, really important that they're having appropriate hormone balance during that time. And we measure that by whether they're having regular periods. Make sure with your teenagers that they're not telling you they're having regular periods because they're taking an oral contraceptive pill. That doesn't count. And again, I'll let you take a look at the relative energy deficiency presentation to get more info on that. Some studies of males have indicated no evidence of adverse effect on sexual maturation related to sports training. Progression of Tanner staging of pubertal development has not been observed to be retarded in athletic versus non-athletic adolescents. And just to finish this topic off, we'll speak briefly about some of the psychosocial impacts on young people with sport. So anecdotally, we do see some risks of burnout from the physical and emotional stress, missed social and educational opportunities, and disruption of family life that come with intensive training and involvement with sport. You can also watch for unrealistic parental expectations or exploitation of young athletes for extrinsic gain, and those can all contribute to negative psychological consequences. Luckily, survey studies suggest that this is experienced only by a small minority of intensely training athletes. That being said, you should have your radar up for this. If a child is old enough, it's not a bad idea to ask the parent to step out of the room and have a frank conversation with the young person about their involvement, whether they actually like what they're doing, whether they're enjoying the sport. So now we're going to move on to part 2. We're going to talk about musculoskeletal issues. We'll start by just discussing some quick overview facts here. So first of all, we're going to look at the next slide with a diagram, but this is going to show us children's bones have more cartilage and collagen than adults. That's what makes them so bendy. So the skeleton is relatively weaker, but they have greater elasticity. That's why we see things like green stick fractures in kids, and we don't really see those in adults. Remember, growth plates are still open in young people. We're going to talk in a couple of minutes here about growth plates and injuries to growth plates and how that can affect kids. Remember, periosteum is more active and promotes rapid healing and remodeling in young people. Children tend to have more injuries to the epiphyses and the apophyses, and we will also talk about some of those injuries coming up in a second here. So first, let's just review a quick picture here of how bone forms. So you start with hyaline cartilage here, and you have a primary ossification center, and then as kind of time moves along here and you get blood vessels in the periosteal bud, then you get these other secondary ossification centers, and later on those secondary ossification centers are actually going to fuse with the rest of the bone. But for kids, you have a time period when everything hasn't fused together yet. One of the pieces of good trivia for you here is crito. So this is the generally very predictable order of how the ossification centers in the elbow appear. Another quick picture here just to review structure. So the epiphysis, the physis, which is also called the growth plate, and then the metaphysis and diaphysis of bone. So let's talk about growth plates. So the physeal plate can be actually weaker than the surrounding ligamentous structures. And this matters because external stress can actually disrupt a growth plate rather than damaging ligaments or soft tissue structures. So in an adult where we might see an injury and expect that the ligament or the soft tissues in the area will be injured, in kids, those structures might be spared and instead the physeal plate will be affected. This matters because injuries to the epiphyseal growth centers are a particular concern because they can actually arrest growth and you can see deformity in long bones, and that's a big deal. I'll quickly put up the Salter-Harris classification. So this allows us to look at physeal injuries. Keep in mind that type 1 injuries can look normal on x-rays. So sometimes with kids, you need to treat them as though they've got a fracture, even though their x-rays look normal. I really like this diagram. It's a quick, easy way to take a look at when growth plates close. So on the left, you have an upper limb, on the right, a lower limb, and the ages at which those growth plates close are indicated next to the bones. So I'm putting this up because I really want you to just take a moment. Anyone under the age of 25 deserves a moment of consideration for how their growth plates might actually affect their differential diagnosis. So it's not just young kids and teenagers, right up into early 20s, you can see issues with growth plates. You may choose to order more x-rays in younger patients with clinical scenarios that you probably wouldn't order them for in adults. My threshold is certainly lower to x-ray kids for concern about growth plates and bony injuries than it is with a lot of adults. So let's talk about some of the reasons that we see overuse injuries in kids and athletic kids particularly. So the physes, the apophyses, and the articular surfaces in skeletally immature athletes are in a rapid phase of growth. That means that they can be less resistant to tensile, shear, and compressive forces that mature bone or more immature prepubescent bone would be. Additionally, we see a decrease in age-adjusted bone mineral density that occurs before peak height velocity, and that can also play a role. Other factors that can contribute are a lack of lean tissue mass, an increase in joint hypermobility, and imbalances in strength and growth, and that can often come when kids are having growth spurts. Additionally, keep in mind that as kids are growing, their equipment might not actually fit them properly. So if it's not adjusted on a regular basis, they can end up wearing things that don't actually protect them. I alluded previously to the fact that kids not getting enough sleep the night before they're active can sometimes increase their chance of having an injury, and overscheduling certainly contributes to this. So keeping in mind that kids who have multiple competitive events on the same day or over several consecutive days might have higher risk of injury. So there are some reasons that we see repetitive stress injuries in young people. We know that tissue maturation progresses non-linearly and unequally. Some of these altered musculoskeletal tissue characteristics can actually distort normal biomechanics in adolescence, and that can increase the risk of overuse injuries. Some characteristics of growing athletes can predispose them to repetitive stress injuries, and some examples that we see are traction apophysitis, so things like Osgood-Schlatter, Sever's disease, and then medial epicondylitis or little league elbow. We can see joint surface injuries like Osteochondritis Dessicans, and then we can see injuries to the immature spine like Spondylolisthes, Spondylolisthes, and vertebral apophysitis. And we're going to get into a few more of the things that we see in young people on the next slide here. So I would certainly recommend taking a screenshot or pausing for this slide. If you don't recognize all of these conditions, it would be a very good idea to do a little bit of Googling and take a read about each of them so that you understand what a classic presentation in history looks like and what your imaging findings would be. Certainly, the examiners have been known to put a picture in front of you that is an x-ray of one of these things and to ask for a spot diagnosis. So it would be worth taking some time and looking at these things more closely. Just briefly, I'd like to do an overview of osteochondritis dessicans. So this is when a small segment of bone begins to separate from its surrounding region due to a lack of blood supply. Most commonly, we see this in the knee, the ankle, and the elbow. And there are some pictures here which show you kind of typical OCD lesions. I'm mentioning osteochondritis dessicans because the acronym OCD can create some problems. Not only is it obsessive compulsive disorder, but it's also osteochondritis dessicans and an osteochondral defect. And there's some confusion there because osteochondritis dessicans can be the underlying pathology which causes an osteochondral defect, but there are other causes of osteochondral defect, so these two terms are not synonymous. So you can see macrotrauma, which causes an OCD, you can see it post-surgically, or you can also see it after avascular necrosis. Another point of comparison I wanted to make is in the pediatric elbow between Panner disease and osteochondritis dessicans of the elbow. So again, these are different entities. First of all, Panner we see at a different age, so between 7 and 12, whereas osteochondritis dessicans is later, between 12 and 17 normally. Panner's disease is idiopathic, whereas osteochondritis dessicans we think is caused by repetitive trauma. In the pediatric hip, there are a number of things that can cause pain. Remember that pain in the knee in a child can be referred pain from the hip, so anytime you're seeing a knee issue, you should also be evaluating the hip. There's a great chart in here that has just a little summary by age of common causes of hip pain. The two pictures that I've put up for you here are in the bottom, a skiffy in the left hip that you can see, and in the top right, Perthes disease, again in the left hip. On the next slide here, we just have a couple of images that show you where the apophyses of the pelvis are. So large muscle groups that attach on the pelvis can often have apophyses, which can be areas of apophysitis or of avulsion fractures. So knowing where these bony landmarks are will be helpful in determining pathology in young people. Take a moment to discuss stress fractures in youth. So stress fractures are likely the most common youth overuse injury. Unfortunately, they're often overlooked, so people will label them things like growing pains and bone bruises and quote-unquote normal wear and tear. We see some risk factors in the pediatric population, but they're really similar to what we see in adults. So overuse, decreased caloric intake, and overtraining are the most common causes. In kids, stress fractures of the foot are the most common stress fractures, and they can occur across the entire foot. The most common ones are actually injuries of the calcaneus. Then we see injuries in the cuboid, talus, navicular, and fifth metatarsal. We're going to talk for a moment about stress fractures of the spine, and I have another slide coming up with some pictures. Usually these involve the pars interarticularis, and that's what we call Spondylolisthes. In youth athletes who have low back pain, this can be present in up to 50% of them, so this should be really on your radar when you're looking at back pain. So just some pictures to show you. A reminder, spondylolisthes. This is unilateral pars interarticularis fracture. That's what you can see just on the far right here. That can be anywhere along a spectrum, so you can see a stress reaction here without a full stress fracture. If we have bilateral pars interarticularis fractures, then you can be at risk of what's called spondylolisthesis, and this can actually lead to instability of the spine and neurological symptoms. The next slide here shows us grading of spondylolisthesis, and again, this is not just a pediatric concern, but something we see in adults as well. You'll see when your imaging report comes back that they'll often give you a grade. Usually with grade 1s, we don't do very much with these, but as they progress, you might find that you need to get more specialist involvement from spinal surgery or neurosurgery. Another spinal issue we'll discuss is adolescent idiopathic scoliosis. So when you're looking at these kids, there are a few etiologies that you need to have in the back of your mind. Things like neuromuscular conditions, congenital neurofibromatosis, and mesenchymal disorders like Marfan's. Overwhelmingly, it is going to be idiopathic, but you should certainly consider these other options. We measure idiopathic scoliosis with what's called the Cobb angle. So The prevalence of this is relatively low. A greater than 10 degree curvature is about 2 to 3% of the population, greater than 20%, less than 0.5% of the population, and greater than 40% is less than 0.1%. The risk for progression of scoliosis is correlated with the potential for growth over the period of observation, and we determine this using the Risser classification. Now, I think that's in one more slide. I thought it was my next slide, but we'll get there. When you're looking at scoliosis, there are some signs on exam that you're going to watch for. So you're looking for unilateral protruding ribs or scapula, a shoulder height difference, protruding scapula, and pelvic tilt. And there's a picture on the side here that shows Adam's forward bend test, and the typical finding is on the right-hand side there, which is the deformity you see with scoliosis. If your x-rays, and these should be 3-foot standing films ideally, show a greater than 15-degree Cobb angle, then we usually want to follow up with imaging between 6 to 12 months if the patient is still growing. Normally we see right thoracolumbar, so the curvature away from the heart is normal. Bracing can sometimes be used to slow progression. Surgical intervention is typically reserved only for cases where there's greater than 25 degrees. I'll show you just quickly this Risser classification that helps us to determine where a young person is in their growth acceleration. So you can see that we've got stages between 0 and 5, and these tell us how far along kids are in terms of their bones fusing. So let's talk about some specific sports. We're going to start by discussing baseball. In baseball, in youth leagues, we often see what are called pitch count limits. And the reason for this is that in youth baseball, there have been some studies that have shown that pitching more than 100 innings a year results in a 3.5 times increased risk of time lost from competition. So in kids between the ages of 9 and 14, we really want to watch how much they're pitching because we see injury risk with this. Quite a bit more writing here on my gymnastics slide. So in gymnastics, peak performance is felt to occur in adolescence or early adulthood. Few elite gymnasts are continuing to compete past their 20s, so that's where we discussed earlier on that they might be specializing in sport a little bit earlier on if they're going to have a real shot at being highly competitive. Commonly reported overuse injuries in gymnasts are to the wrist and to the low back in female gymnasts, and then to the shoulder and the elbow in male gymnasts. Spondylolisthes is actually a common finding, and this is hypothesized to be linked to the back walkover type skills. Wrist injuries, including stress fractures and growth plate injuries, are also commonly seen as the upper extremity is weight-bearing in gymnastics. One of the ways that we might try in gymnastics to prevent injury is to develop practice schedules that must incorporate time on multiple pieces of equipment. Short stature in gymnasts has been considered most likely a consequence of genetic and physique preselection rather than a result of training, but some have actually concluded that training starting before and maintained through puberty can alter growth rates. I've seen a couple of these in my practice so far. So distal radial epiphysis injury can actually cause alterations in the radial ulnar growth in highly competitive gymnasts. So when you see that gymnast coming in with wrist pain, even with normal x-rays, you have to consider that you might be seeing a physeal injury or a stress reaction. There is some interesting information coming out around hockey players and their hips. So even though hip and groin sprains have been reported as a leading source of injury among hockey players, there is actually growing evidence that's suggesting that femoroacetabular impingement, or FAI syndrome, might be actually the primary source of hip and groin injuries in youth athletes. There have been studies that have looked at hips in hockey players and found that hockey players had higher alpha angles, which are associated with cam-type impingement. Importantly, this incidence increased with age and with athletic participation. The elite level athletes in the older groups, so 16 to 19-year-olds, had a higher incidence of labral tears as documented on MRI.
Even though they didn't look at the numbers of training, this was one of a few studies that clearly demonstrated that participation in youth athletics could actually lead to detrimental bony changes during growth that can come back and cause problems later. So FAI might actually represent an overuse injury from playing hockey during childhood. Swimmers typically swim between 4 and 9 miles a day and often swim 11 months of the year beginning at ages 10 to 12. The most common thing that we see in swimmers are shoulder issues. The pathologic process that we hypothesize is from a combination of external impingement and the development of generalized laxity, followed by insufficient rest and recovery. So there's a study here that found that 91% of swimmers reported shoulder pain, 84% had positive impingement signs, and 71% had MRI evidence of supraspinatus tendinopathy. So although their stroke performance did not correlate with their injury and shoulder pain, both the number and hours of week and the weekly mileage were significantly correlated with supraspinatus tendinopathy and pain. So long-term consequences of shoulder pain in swimmers are unknown because we haven't done those long-term changes, but we can theorize that the rotator cuff is going to be affected over many, many years of competitive youth swimming. So that's it. Take a look back, dig into some of the issues that we haven't had time to get into in a lot of detail. I want to send out some thanks to Dr. Mark Leung and Dr. Neil Dilworth at the University of Toronto, who both provided resources in the preparation of this presentation. There's some references here that you will see throughout the presentation. Certainly they're worth taking a look at, and good luck. Thanks.